another question about the reflux. When you eat, if it's too tight, it can come back.
It will come back up, yes.
Again, a simple thing, but most of the obese patients already have got reflux.
Yes.
This is something very common.
Very common.
In every house, you will find an antacid tablet.
Yeah.
So, obesity and gastric reflux go hand in hand. Pre-existing gastroesophageal reflux disease patient should not be taken up for sleeve gastrectomy.
Yes.
But with Roux-en-Y and the MGB,
Yes.
in MGB again, because of the wide outlet, it's a low pressure system.
Yes.
Earlier, we used to think that maybe in MGB the chances of reflux would be high.
Yes.
Because in this single anastomosis,
Yes.
these juices are traveling here.
Yes.
The bile and the gastric
yes,
juice and liver and pancreatic juice. And there should be some chances of the juice going up into the food pipe.
Yes.
That is why there was some stigma attached to the mini gastric bypass in the beginning.
Yes.
But when we look at the beginning, what happened, actually there used to be one Mason's gastric bypass, which was actually the first gastric bypass. This is the Mason's gastric bypass.
Yes.
This is actually, this was done by Professor Mason from US.
Yes.
And he is considered as the father of bariatric surgery.
Yes.
And he constructed this small pouch out of the stomach
Yes.
and then brought a loop of the intestine and hooked it here.
Actually.
But the inlet and the outlet were too close.
Yes.
And there was high incidence of this bile going up into the food pipe.
Yes.
And this procedure eventually got converted into Roux-en-Y gastric bypass. What they did in Roux-en-Y, they cut this tube which was carrying the juices
Yes.
to this pouch,
Yes.
and then they brought this tube down so that the juices cannot go up.
Yes.
If you look into this Roux-en-Y, now this loop was carrying the juices, which was actually here in the Mason's gastric bypass, and now it's here, so that the juices cannot go up. That's how Roux-en-Y actually came into being.
Yes.
And if you look into the obese patients, already there are about 15 to 20% chances of reflux before surgery.
Before surgery.
If I ask this question to 10 patients, do you have reflux? What about you? Did you experience any acid symptoms? Yes. So this is a common answer.
Yes.
So I need to do a procedure which should have some chances of decreasing your reflux.
The reflux, yes.
And here we go now, after 20 years of mini gastric bypass, now we understand that it is actually an anti-reflux procedure. Because at the outlet there is no pressure, no bend, outlet is wide, and at the inlet there is a valve, so when the things go down there is no reason why they should go up. Again, going by simple Bernoulli's theorem, that if the outlet is wide, why should it flow back? So that is what we can demonstrate now, and we can see as it comes from different countries now. So probably that long tube changed the Mason's loop into mini gastric bypass, and now Professor Rutledge says that maybe the Roux-en-Y, which was primarily constructed or designed to decrease the chances of bile reflux, has been able to decrease the chances of bile reflux. That's for sure. But still, there are 1 to 2% chances of reflux with Roux-en-Y because of the tight outlet. When you eat, it comes back
up.
The chances of stricture because of the too tight outlet are high in Roux-en-Y. So stricture would mean that you cannot eat solids. So then we have to dilate the outlet. So these things the chances are very low with mini gastric bypass because the outlet is wide.